So we'll start with basically where your nerves coming from after they leave your spinal cord. So you see that this is the spinal cord, and what's the motor unit mean? It's basically the nerve connecting the muscles leaving the spinal cord. And that's another view that's showing like part of the nerves go to your skin in charge of sensation, and we call them sensory nerves, and part of these nerves supply your muscle, we call them motor nerves. And that's the nerve itself. It's like a bundle of wires, basically. Each tiny dots here is another nerve, and this is the whole bundle of wires. And each nerve have blood supply, you need to survive. I mean, and this is, some people have neuropathy because inflammation of the blood vessels themselves. We call it vasculitis, inflammation of the blood vessels. And that's the actual nerve itself. The head of the nerve, which is over there. This is the head of the nerves, and that sits and lays in the spinal cord, and that's the terminal that goes either to the skin for sensation or to your muscle to help you with movement. Now these nerves leave your spinal cord. Let's go to the picture over it, and that's your spinal cord, and these are the nerves. They just leave. And there's 31 pairs of these nerves from your neck all the way to the bottom. That's what, if you saw surgeons or somebody told you, oh, you have pinched nerve in your back or your neck, that's what it is, because these are the same nerves. Could go all the way down. If it's affected all the way down is neuropathy, but if they pinch them in the neck, it's different disorders. So the nerve physiology is a little bit complicated, but I'm going to make it very simple. It's the concept they call it action potential. Okay, this is present in all animals and plants, and so the action potential basically depends on this. This is a better picture. Like you have the sodium and potassium that's sitting inside and outside the nerve. You don't need really to understand much about it. Basically, these electrolytes in your nerve determine how the nerve pulse is moving, okay? And this balance is important. That's why if you have electrolyte disturbance, you have nerve issues. And that's why your doctors checking these electrolytes to make sure you're okay. Also, that's why some medication to stop the pain block the sodium here, like Topamax, Lamictal, all these medications. Why? Because it stops the sodium from moving and reduce the pain. So neuropathy in general, it's many types. I know we all say, oh, I have neuropathy, but it's not like we're saying I have an infection. It's like so many types, and today I'll try to hit most of the types. So neuropathy, basically, the term neuropathy is basically neuro is the nervous system itself, and pathy is the disease. So it's basically meaning nerve disease. Causes are so many. It's probably 100 or more, ranging from acquired causes like diabetes, high triglyceride, vitamin deficiency, you name it. Could be hereditary. Could be medications you take, like the chemotherapy or other medication. Could be alcohol consumption. All these could cause nerve damage. If the neuropathy affecting one nerve, we call it mononeuropathy. If the neuropathy call it multiple nerve, we call it polyneuropathy. And that's, you might see it if your doctor diagnosed you, you will see in the report saying polyneuropathy. That's mean multiple nerves. If it is symmetrical, that means even both limbs, both sides. If it's not symmetrical, we call it asymmetrical, or we call it multifocal. Also, neuropathy could be chronic. That means it's going on for weeks, for months to years, gradually. And there's some neuropathy happen, boom, within like a couple of days to a couple of weeks. And these are the ones that, I don't know if you heard about Guillain-Barré or these type of severe neuropathy, you get really weak quickly. And I will touch base with all these. Now, some neuropathy, we don't know what's causing it. And you might hear your doctor saying, we call it idiopathic. That means we really don't know what's causing it. And that's a good chunk of the neuropathies, which is almost 45 to 50%, we don't know what's causing it. Even if we test everything in the the textbook, we don't find it. Symptoms depend which nerve is affected. So if you affect the sensory symptoms, which is the one that goes to the skin, you're going to get the sensory symptoms, which is you're going to get burning pain, numbness, tingling. Of course, that's going to affect your balance, because these are the nerves that give the signal to your brain, to know where you're at in the space. And, if you go to the doctor, the neurologist who sees you, when they make you close your eyes and see if you're swinging like this, that's an indication these nerves are affected. If the motor nerve is affected, it's very obvious. You're going to get weak, okay? Now, the other entity, which is really underestimated, is the autonomic neuropathy. That means the nerve in your viscera, the nerve that goes to your heart, your stomach, the sweating, the eyes. So this causes a variety of symptoms. Some of them are really inconvenient or dangerous. For example, if it's affect your heart, it's going to affect your blood pressure. You're going to start basically get lightheaded every time you stand up, and sometimes you pass out. Sometimes, if the neuropathy is severe enough to affect your stomach, you get bloated easily with food, and you have to have frequent meals, and you get chronic constipation. It could affect the bladder. It could cause erectile dysfunction. It could cause also severe blurry vision. All these autonomic symptoms because it's all over your body. So let's start talking about the common neuropathy. The first one is the common. Probably most of you here in the room, if you have neuropathy, that's what you have. We call it peripheral axonal neuropathy. That means the nerve itself is affected, not the sheath around it, or the covering of the nerve. So usually these, you present both lower extremities, both feet start getting numb, tingly, your balance is off, and this burning pain gets more and more severe. And some people get only numb, they can't feel it. And then you get discoloration of your feet, and you don't feel the temperature like in the bathtub. You can't tell if you touch the water with your feet if it's hot or cold. And as it progresses, you're going to start getting weak. Even I ask some of my patients, I would say, spread your toes, and they laugh. They say, I can't, I've never been. But you should be able, I start with, because the weakness starts very distal and then gradually go up. And then with time, you cannot even bend your foot because you're going to start having maybe foot drop, if it's severe enough. What's the causes of one? The most common causes, of course, if you are, in your 50s or 60s, this could be diabetes. B12 deficiency is commonly to cause this one. Thyroid disease. It could be medications, alcohol. People come to me, they already have rheumatoid arthritis or they have lupus. It's another immune disorder, and the neuropathy could be part of it. Vasculitis, which is it's really a bad, I wouldn't say bad diagnosis to have, but it's really diagnosis often missed, which is inflammation of the blood vessels. And if it's happened, it's caused really severe weakness because it's going to hit your nerve and cause a stroke in the nerve, not like a brain stroke, like the nerve itself died. And also there's infection like hepatitis C. If you have an old hepatitis C, it could cause neuropathy, HIV, Lyme disease. And the bottom line here, idiopathic, which is we don't know what's causing it, roughly 50%. And I tell my patient, if you have idiopathic, probably it's better to have it not knowing because they tend to be more mild. So the workup, basically, all I do in the clinic is just send a lot of blood work to try to sort out which one is which. And I do the nerve study that everybody likes, to figure out what type of neuropathy do you have. And then if the nerve study is normal, while you still have the symptoms, I have to do skin biopsy. And skin biopsy, basically, I'm going to check certain types of nerves in your skin. And I see this a lot. Patients go to the doctor, send them for nerve study. They look like neuropathy, but the nerve study doesn't show it. When they end up with me, they end up with a skin biopsy. And then the question, how do you treat them? The treatment, you have to treat what's causing it. Like if you have diabetes needs to be taken care of. If you have vitamin deficiency, you need supplements. And then you treat the symptoms with the pain management. And basically there's not much. There's gabapentin, Luricus, and Baldwin, and we all, most of you probably know it. And then if it's hard for me to manage, I refer to the pain clinic. But trust me, if this medication doesn't work with you, I don't think the other strong medication like narcotics are gonna work. Because what we call this is nerve pain, so the narcotics doesn't really work well. So small fiber neuropathy. So what's the small fiber? It's small fibers. You cannot, the other nerves you can feel it. You can touch here, the elbow, the funny boarding, you can feel an actual nerve rolling under your finger. That's the large nerve, and that's what we test when we do the nerve study. And if these are normal, the nerve study cannot check the smaller nerve, the nerves that are inside your skin, and actually they're all over your body. And these nerves mostly in charge of pain, especially if you have a severe burning pain, and the numbness sensation. Okay? So what we do is we do the skin biopsy, and I'll give you an example, to look at these nerves actually under the microscope and see if they're damaged. And if you have it, sorry. And if you have it, then you have neuropathy, and we do exactly like the other type, the large fiber or the peripheral neuropathy, not everybody. And to diagnose this, your EMG have to be normal. I'm not talking normal in terms of no pinch nerve. No, I'm talking doesn't show the other type. So this is part of the diagnosis before you jump and do the skin biopsy. We talked about the symptoms. It's the burning pain, the shocking-like symptoms, the numbness. With this type, people get the autonomic symptoms. And I divided it for you guys. It could be heart when you pass out. And it's funny, I see these patients, they're already on blood pressure medication to lower them, but they pass out. The reason for that, when they go to the primary doctor, when they're sitting there doing nothing, or they're laying flat, their blood pressure actually high. So the primary doctor say, oh, you have high blood pressure, let me put you in medicine. But the problem is not when you're sitting or when you're laying down. The problem when you stand up and walk, or there's some temperature or exhaustion, your blood pressure will bottom down to 60s or 70s. And I always have a hard time to negotiate kind of the primary care. I tell them what's going to kill my patient is the drop in the blood pressure. It's not the high blood pressure that you're trying to treat. So this is really a touchy thing, and I try always to educate my patient about it and teach them that if you have neuropathy and you start getting lightheaded and about passing out, we need to know, okay? The other symptoms, just like I mentioned earlier, you could get constipation, your stomach get distended after food, you could have incontinence, urinary incontinence, erectile dysfunction, sweating. You start over sweating your chest and neck, but you don't sweat in your feet. This is also part of the neuropathy. And then you get a dry mouth, dry eyes, and all these symptoms. Now what's causing it? I'm not going to go over this. It's exactly the same that the other type. Okay? It could be medication, I check for diabetes, and things like that. By the way, this entity used to be mostly in young, like 20, 30 years old, patients. More and more I see patients in their 60s and 70s come to me with the symptoms of neuropathy and the EMG is normal. So it's really not something specific for young patients. Now, what do I send? I send exactly the same. I check you for diabetes, I check you for high triglyceride. It surprised me not a lot even of doctors know a very high triglyceride. We're talking about 300 to 400. And it's on-cause neuropathy. And when I receive these patients, they say, oh, nobody knows, and then the triglyceride is sky high, not the cholesterol triglyceride. And usually they get careful neuropathy. The triglyceride need to be controlled, and we call it metabolic syndrome. It's usually associated with high triglyceride, being overweight, and things like that. That's the skin biopsy. You just attach the picture, and basically the little black lines in your skin, these are the nerves, okay? And all I do is I count these nerves going up, and that's in the pictures showing. I just count them. And I look at the nerves. This is a better picture. Like this nerve, for example, has swelling. That's indicating really bad neuropathy. Here, there are very healthy looking nerves. And here, there is no nerves at all. There is only a bundle in the bottom, but nothing in the top. That's a severe neuropathy. So GBS, Guillain-Barré syndrome. And so what it is basically it's autoimmune disease. Hit you very quick, and you end up weak. Most of patients had preceded by infection. Like I asked them, did you get flu? Did you get diarrhea before, 2 weeks before? They say yes. Did you get a vaccine or a new medication? So usually triggered by something. This is a life-threatening disease. Mortality, 50-50 back in the days. You get it, your chance to die 50-50. Now, it should be not more than 2 to 3%. So what's happened? Within a matter of 24 hours, 3 days, you start getting numbness and tingling in your feet, gradually go up, and then you get weak, and then you can't chew, you can't breathe, and then gradually you're like paralyzed, as simple as that. And this is where it's first described, 1859 first described, and that's Guillain-Barré who first described it fully and like gave it the name. And this is, he actually died a few years ago. He gave it, and we call it the variant. Instead of starting in the legs, it starts in the face. So sometimes people present to the hospital, they cannot swallow, it looks like a stroke, they don't memorize, doesn't, memorize okay, and then this is a variant of the GBS, the Guillain-Barré syndrome. So two-thirds of cases is URI, which is respiratory infection, and stomach bug, basically. And then other infections could cause it. When the H1N1 vaccination come, a few cases also got reported. And actually, when you go to vaccine for influenza, it asks you if you had GBS in the past, if you read it. I mean, the case reports is like 1 per 50 million, but it's happened, okay? What other medication could cause it? So it's really could be associated by many, even sometimes people with lymphoma get vaccine, like more complicated picture. Basically, your immune system attacking these nerves. This one actually, I mean, it's kind of, I would say, it's lucky you have it because it's treatable. Okay, treatment even, it's life support because if you can't breathe, they have to put you under breathing machines. But you can get IVIG, you can get a plasmapheresis. They pherese your blood, they clean it up from all these antibody that your body attacking the nerves. And 90% of people really recover. And the other 10%, they have residual problems. But the recovery is really good. And the mortality should be almost very close to zero. Most of mortality is mismanagement by doctors, actually, rather than the disease itself. Either delayed diagnosis, either they overtreat, undertreat. That's why sometimes going with these rare diseases, you need to be in a bigger center rather than somebody never seen it before. I added this topic from the last year. This is another type. It's like GBS, but it's the chronic. It's not really as GBS itself, but it's the same concept. It's your body attacking it. This is another disease, I would say, if you have it, kind of it's a good news because it's treatable. The name is chronic inflammatory demyelinating polyneuropathy. Everybody knows it as CIDP. This is developed over 8 weeks. You get gradually weak, and you lose of your sensation. Not years, gradually. But in my clinic, in my experience, I saw people years because it started quickly, but it's not diagnosed. So they end up in wheelchair, basically. And at that point, it's hard to diagnose and hard to treat. So early diagnosis and treatment for this disease is important. So anyway, so that's the criteria for diagnosis. Basically, 2 months progressive, very weak, more than the sensory loss. You don't really present with pain. Mostly weakness your complaint. You don't say, oh, I have burning pain, that's the other types. This one mostly weak. And not just your feet, like the other type of problem. Like you weak all your legs, start your thighs and your feet. And I had a recent patient, and they tell me, I cannot stand up from a chair because you use your thigh muscle to stand up from a chair, or you go upstairs or downstairs. If you have neuropathy, you don't have a problem standing up from a chair. The problem is your foot. You don't need your feet to stand up from a chair. So anyway, progressing over the time, and then usually affect male, and they're roughly in their 60s, 50s to 60s. It's about 4 to 5 per 100,000. So in Austin, I expect to see what, like 50. And then in the age group of 70 and above, it's more common. It's 1 in 10,000. But the problem at the age group, there is a lot of, sadly to say, there's like, you get dismissed. Oh, you have diabetes, then this is neuropathy, nothing else what you've done. That's why I always get this question. Doctor, I have neuropathy, and I have diabetes. Why do you do the nerve study? You know already. And the answer is no, is to look for this. Because if I find this is treatable. But if I say, all right, you have neuropathy and you have diabetes, no treatment, that's when we are setting up for trouble. Okay? So anyway, it's very underdiagnosed, especially in this age group. And the more it's left, the more hard to diagnose. Why? Because the nerve damage is so bad, there's no nerve to study. I can't biopsy the nerve because it's dead. I cannot do the nerve study because there's no signals, the nerve is dead. So I have to believe you have the disease, and have the faith you have it, and then throw a dangerous medication in you and its side effect, just without any objective evidence. So how do we diagnose it? We usually do spinal tap to see if your immune system overactive, especially at the CSF. We do nerve study, and sometimes I do nerve biopsy and spinal tap. Okay. How do you treat it? You can put steroids, especially if you are healthy, not much. You can use IVIG, especially if you have diabetes, steroid doesn't work with you. Plasmapheresis. It works, but it's much complication, and also you need a catheter. It's like dialysis. So it has infections and more complications. Anyway, the recovery is good, but the catch in this disease, it's treatment dependent. That's when you get hooked up to this treatment for the rest of your life. A third of patients get symptoms free, hopefully, but about 70% they have to stay in this treatment. Okay. Yeah. Other medication we use, if the above fails, these are we call them chemotherapy or immunotherapy to suppress your immune system. Entrapment neuropathy, sorry, I'm jumping between topics a lot. Entrapment neuropathy is the other type of neuropathy, like the carpal tunnel syndrome. Probably most of you guys know what it is. It's another nerve entrapment. Entrapment means the nerve gets around the joints, the nerves simply get entrapped. Happen mostly with people who have diabetes. This is important to know because it's kind of treatable with surgical release. So people with diabetic neuropathy, their nerves for some reason are more prone to get entrapped around the joint. So what's the common ones I see in my clinic and in every practice is carpal tunnel syndrome, which is the median nerve, ulnar nerve here in the funny bone, and in the feet as well. Carpal tunnel syndrome is very simple. The nerve entrapped in your wrist. You're going to have numbness and tingling and pain, but mostly in your dominant hand, not the other hand. It has to be dominant hand. And it wake you up in the middle of the night, numb and tingly, you shake it, and it's even called shaking sign. And it's very specific. You get nerve studies on how you have diagnosis. Treatment is simple. By surgical release. We start with the simple brace. doesn't get better, injection doesn't get better than symptom. Very straightforward. And that's the distribution, where the sensory loss and also the pain in your hand. Now, carpal tunnel syndrome doesn't cause weakness, but patients say, I'm weak, his hand is numb. But it does not, because the nerve doesn't supply much of the muscles here. Okay, so if somebody comes to me, really his hand is weak, it's going to be stupid from my side to say, oh, you have carpal tunnel. I have to look for other places. Okay? But this is the other nerve, it's called ulnar nerve. It's behind your elbow, it's got a pinch. If I do nerve study in you guys, probably a third of you guys have it. Why you guys don't show up to the doctor? Because it's painless. When do you show up? When you really cannot open any jar anymore. And your hand's really, really weak, which is too late because the muscle is damaged and the nerve is damaged. So usually it's trouble with opening jars, as the grip is weak, and you don't have pain. Maybe you can be a little bit numb in your pinky, but it's not much to bring you to the doctor. Okay? And the treatment is very simple again. You just release the nerve here from the entrapment, just from frequent use, which is the funny one. Okay? Now the surgery is not going to give you your strength back, actually. It's to prevent further weakness. That's why catching it early is to prevent further damage. Again, the diagnosis is nerve study. So nerve conduction study. So nerve conduction study is a very pleasant study. Everybody likes it. It's very simple. I'm going to zap you with electricity until you give me all your money. And then after that, it's not the end. I'm going to stick you with a needle in your muscles. Sometimes you're lucky, you end up with a few sticks. Sometimes you end up as many as 20, depending on what I'm looking for. Okay? It's the guy who invented the concept of that, he did it in the squid, because the squid have the biggest nerve axon that the man known, and he got a Nobel Prize for that. Anyway, so why do we do it? We do it to diagnose you, we do it to know how bad it is or how it's progressing, we do it to know if your neuropathy not symmetrical, like you have one side more than the other significantly, not a little bit, that's probably not a typical neuropathy. Maybe you need a nerve biopsy or something else. You start to indicate immune disorder. Okay? So that's where the nerve study is important. Okay? What's even more important, give me an idea if you have the other diagnosis we call CIDP, which indicate it's treatable. Okay? What else? How chronic it is? I got these cases. There was a case when I went to follow. There's some compensation case, legal issue, and patient said this has been going on for years. For like a month. I needed compensations, and whoever some work related, and he said no, he thinks it's not. And we did the nerve study. Nerve study tell me how long you had it. So I could tell easily if the patient had it for years or for months or a couple weeks. I can't tell. And that's the beauty of it. Okay? And we're not done here. It's also going to help you for a muscle disease. If you have myopathy, which is a muscle disease, it helps you diagnose other disorders like myasthenia gravis, which is it's other immune disorders beyond the scope of the lecture today. Basically, that's what I do. These pictures are actually from my fellowship. So it's very simple. I stimulate you in one hand with electricity, and I record from your muscles. And there's a wave like this or like that. It will show up. I measure how big is the wave, how quick is the signal, how fast. Usually most of our nerves are about 50 meters per second, very quick. And then I match it to your gender and your age, and I know what's normal and what's not. It's very straightforward. And then the EMG, it's a needle, not that big, it's a small needle. And then we stick it in the muscle, we record the electricity. It's painful because while the needle inside your muscle, I ask you to move. So basically, your tissue is just squeezing the needle, and that's where it's painful. That's it. Thank you. Now the EMG is very important, and I always in every talk, I don't want to be biased or I don't know how to put it. Please make sure who does your EMG kind of a board certified, I know it is. You're going to be struggling with this test. It's painful, it's not a nice hour to spend, and then you come to me and I will tell you, or another neurologist, that's a bad quality study. A lot of people did this study, and actually Medicare, sadly, instead of, because it used to really reimburse good, and Medicare, what do you call this game for the kids when something pops out and you hit it? Whack-a-mole. There you go. So Medicare, that's their strategy. Anything used, overused, they hit it. So EMG has been used by physical therapists, by chiropractors, by general doctors, medicine. And then Medicare said, hey, we're bankrupt here. So they cut it by 70%. 70. And a lot of doctors stopped doing it because it's not worth it. The time or the machine is very expensive. So to stop this, and this is applied to every aspect, if any test, just please make sure the neurologist who does it have enough training. So at least if they refer you, somebody else can look at it and say, yeah, that's a good quality study, I'm not going to repeat it. And this is rarely happening. I always do supplementary, they miss this, they miss that. And sometimes they get upset because it's totally unrelated to the problems. And it's hard really to convince the patient to do it. And it's harder to let the insurance pay it twice, which is really, we have to lie sometimes. Like change the diagnosis, we play around because it's expensive. And so that's my advice about EMG. It's painful, and if you're going to do it once, it has to be done the right way.
I know if it's the right.
Just ask the doctor. It's very like, well, if you have a problem with your heart and you want to get echo, would you rather cardiologist do it or just regular doctor, right? Common sense.
Well, if you have sudden severe pain, is there any, if you're sitting at home and it's sudden severe pain in your feet or your thumbs, is there anything you can do to help yourself?
So if you have a sudden severe pain, on top of usual, okay, so you're diagnosed, you have on and off mild pain on some days, so you have a bad days. You have bad days?
Really bad. What can you do for yourself?
So we call it rescue medicine. It's really hard because most of the nerve pain is dependent building up the medication. So if you're gabapentin doesn't work overnight. I know some people say I take extra pill, but actually you're helping yourself psychologically because it doesn't make sense. This medication has to build up in your body. So to avoid these kind of things, you have to really be in the right dose for a while. Using Vicodin or Narco for these instances is a recipe for addiction, so intolerance, fall, because you already on balance with neuropathy and then you're drug out, so you now fall. So there is other things, using heating pads, these kind of massages, but I think if you are the correct therapy, you just build it up in your system, so even if you have a bad day, it's not going to be that bad.
So how many types of neuropathies are there? 3?
No, many.
Many.
I just gave the common things.
Okay, and how many can you actually cure? 1?
No, so, no, that also many, because if you have a diabetes caused by for example, vitamin deficiency, or, you supplement with vitamins, you get better. If you have secondary to bad thyroid management, you supplement it. If neuropathy because of medications, you stop the medicine or you change it. These are considered treatable. Other neuropathies, the autoimmune, like the CIDP, the one associated with lupus or RA. If you treat the underlying disease, you you get better. The same applies to diabetes. If you manage your diabetes well, it will help with your neuropathy. It's not going to stop, it will help.
So 50% you can tell by a skin biopsy?
No,
No.
50%, the number 50% was the idiopathic, which means we don't know what's causing it.
Oh.
45. We're getting better every few years. Yes, sorry.
How does neuropathy differ from dystonia?
Neuropathy and dystonia. The only cases I've seen the correlation is, I have a few patients with entrapments here in their hands. And that causes dystonia of the hand. Nobody knows why. Injury to the nerve here, and then your hand becomes like this, and your muscles. That's dystonia. But the actual classic neuropathy, the answer is no. Oh, sorry.
Say again what EMG is.
EMG is a nerve study. You can Google it. EMG is a nerve study, basically zapping your nerves with electricity. And then I record the signal more distant to see how big is the signal and how fast it is.
Is this one of your first type of diagnosis, or?
Yeah, I usually do it with anyone with the symptoms of neuropathy to start with.
So that gives you some clues in which direction to go.
Yes, that's exactly what it is. Is it the classic? Is it the other type that I can treat? Is it, it's part of the diagnosis.
Is carpal tunnel any relation to neuropathy?
Is carpal tunnel what? I'm sorry?
Has it got anything to do with neuropathy?
So again, as I mentioned earlier, if you have neuropathy for whatever reason, you tend to have what you call sick nerve. Your nerves tend to get carpal tunnel, like they get entrapped and pinched easier. So it's not like carpal tunnel. It is neuropathy, but it's a subtype of neuropathy. We call them entrapment neuropathy. That's when the nerve is got entrapped into the joint. Okay? Because remember in the beginning of the talk we said the word neuropathy, like saying infection. It's just very broad. There's many types of neuropathies.
The reason I was asking, I recently had carpal tunnel on one hand and the other. One of them pretty bad. Probably went too long. But it's still got the numbers.
Well, that's the thing. So the nerve study will help to sort out, is it really carpal tunnel? Is it carpal tunnel plus neuropathy? Is it carpal tunnel plus neuropathy plus pinch nerve in your neck? That's where the nerve study will help.
Do you a member of a clinic?
I'm what?
Are you a member of a clinic?
Yes.
How many people are in it?
Just me. I don't play games.
And you're in Austin?
Yeah, well, I'm in Georgetown.
No.
I like
This
to
information is on the.
Yeah, I used to be part of the bigger group, but I decided to be more specialized in nerve disorder. I used to do general neurology, but I stopped doing
So, my wife has a pinch. They did an EMG, and they confirmed that the nerves were.
Yes.
So, what next? Surgery?
that. Well, I don't know. I mean, I don't know your wife, but depend. I mean, of course, in the severity, the MRI of the neck, it's a lot of things need to be before deciding how bad it is. Did physical therapy work or did it work? Things like that.
Yeah, because the neurologist that we saw basically said, here are the results, go see your primary doctor.
Well, I mean, well, from there, because it's not, technically it's not general neurology, it should become a surgical issue. Because this is a mechanical. Does it make sense? It's just like carpal tunnel. Neurologist diagnose it to you, maybe make you wear the brace, but once you need surgery, neurologist is not a surgeon.
Most of your work, most of your work covered by insurance.
I'm sorry.
Most of your charges covered by insurance.
Yeah, I mean, I try really. If the insurance allow me to be contracted, I think contract with most of them.
I have a question, because you asked me. Are shoes a big help, different types of shoes? a big help from neuropathy?
Yeah, so the thing is, because the weight distribution, I mean, I don't have the knowledge about what shoes is good or, but pediatrists usually do a good job because with time, because you lose your balance because of the nerve damage, the weight distribution will be off, and that will affect also your knee. So that's why they pick certain shoes, certain gel, like there's all this technology to distribute the weight. Yeah, go ahead.
If it's idiopathic, is there treatment or what do you do?
No. The only time when I decide to, I don't treat blindly, okay?
Don't treat what?
Blindly. I don't throw medication unless I have a diagnosis. The only time I treat somebody with idiopathic neuropathy, if they're progressing so fast, like within a year, somebody come to me and say, hey, I was walking 6 months ago, now I'm in a wheelchair. And if I can't find out what's going on, now it's worth the risk. I could start in, immune suppression, something as a trial. And of course, I'm going to do nerve biopsy, EMG, I do everything to find out. Because what if they have ALS, like already, right? It's not working, it's untreatable. So if I don't reach to a diagnosis, I might do the blind trial, and I don't do it that often, it's rare. Yeah.
Idiopathic,
If it's idiopathic and progressive, yeah, you just live with it.
just live with it.
Yes, that's the bottom line.
I got a question. Let's say that most people will come in and say it's idiopathic. How many times do you determine that it's something else? If there is a particular cause for that.
I'm biased because I get the neuropathy that the general neurologists get confused with. So usually, because my referral are through neurologists, most of them. So the neurology figured out, oh, it's the classic, idiopathic, he's not going to refer it to me. But if he get confused with the study, with the diagnosis, you're going to come to me, I'm going to find the answer. So I'm the other way around. Most of my neuropathy patients, actually, they have the reason. Okay? The only exception is the small fiber. There's not a lot of physicians look for this disease. And for a small fiber neuropathy, if it is idiopathic, it's idiopathic, the same. There's not much.
Is there a relationship, or can there be a relationship between sciatica and peripheral neuropathy of feet?
So what's sciatica mean? You mean the pinch nerve?
Well, yes.
Well, again,
Yeah.
sciatica is a mechanical issue. That's
Okay.
pinch nerve or something related. There's no direct relation, but again, people with neuropathy, their nerves tend to be sick, so they entrap it and pinched easier.
Okay.
Even they have a name for it. They call it double crush syndrome. That's mean.
Oh,
You pinched in your neck, and then also you are neuropathic somewhere else, and they don't know the exact reason why.
okay.
Yes, sorry.
If my husband's been to a neurologist and they do the general test where they put, try to push my leg up, try to push my leg down, feet back and forth. But he's gotten severely worse in his balance and his being able, weakness. He doesn't, it's just the weakness in his legs that he can't walk. Is it,
Over a period of how long?
just, that part has been maybe over like 6 months that he's gotten to where he now needs to have a walker even in the house.
So that's where it's
So
a red
is-
flag. This is
is
not
that-
idiopathic.
Okay, so that's where we should assume it's that CIPD? No?
You can assume it. Of course, it's a good idea to put in the back of your brain. You need to look for more. Is it, you need to.
Okay.
Anything progressing that fast in terms of weakness,
Right.
CIDP, Lou Gehrig's disease, these kind of things. Looking for cancer, like it's really, it's a very comprehensive workup, and it should not be let go. Being in a wheelchair within 6 months or a walker, you don't let it go. You have to get to the bottom of the problem. Alrighty. Oh,
Can you explain why it happens more in the evenings and night than the daytime?
the neuropathy? I don't know. I think it's a distraction. Like, she asked why the symptoms is worse at night in terms of probably cramps and pain. And what they call restless leg syndrome, which is basically neuropathy. It's the batteries. It's basically, my theory is the distraction. You're more distracted during the day. And also you used it all the day, and now you're paying back at night. That's the only, I don't have really a science. Yes?
How long does it take to get an appointment with you?
Oh, thank you.
I have one Monday.
James.
I really don't know. Jean, how long? How long does it take an appointment? Jean is my office manager.
About 2 weeks.
2 weeks.
Okay, good. So I'm not working hard enough. I should be free. All right, thank you so much.